coordinate state activities in between doing all your COVID duties. All our teaching HODs have been very cooperative to the initiation of this program. So I thank and welcome Dr. Purushothaman sir, Dr. Vinod, Dr. Ramraj, Dr. Rajagopal, and Dr. Verma. Best of luck to Dr. Paulos, who's presenting the case today. You have nothing to lose today. Only I would say you are very lucky to be presenting to a veteran today. Then welcome to each and every delegate. I can see many seniors here, Komlavali madam and others. Over to you, to the state president for the inaugural, for the presidential address.
Yeah. Thank you, Dr. Reddy Shandagama. Dr. Andayeswan, National Vice President. Dr. Sridhar sir.
Request all of you to mute. Please mute Dr. Venugopal, Dr. Kuryakos. Please mute yourself. Okay.
Yes. Yeah. Sorry. Dr. Andayeswan, Senior, National Vice President also. Other senior members in the profession, my dear colleagues, and dear PG students. I'm very happy to be here when IAP Thrissur branch is launching a postgraduate teaching program on a bi-weekly basis. Some
Narayana, not audible. Narayana, unmute.
Yeah. I was not audible till now.
Yeah.
Yeah. Okay. Many branches are starting this type of program, and now Thrissur branch has come up with a project like this. And this will be, as it is mentioned in your brochure, it will be a back to school program for the practicing pediatricians and an excellent exposure to teaching to the postgraduates. And for teachers for teachers of the present generation, when their teachers like Srinivas are there, so teachers of teachers will be there, so that these great teachers can see how their students are teaching. So it will be an excellent program. And also, since there are many medical colleges in the city, so all the students will be able to see the important cases admitted in any hospital or medical college in the city. So congratulations to the Thrissur branch for taking this initiative. And I wish this program all success. And to the postgraduate students, it is a great opportunity for you. So please make full utilization of it. Thank you. Thank you.
Unmute.
Next will be the inaugural address by Dr. Anandakeshwan, National Vice President.
Good evening, respected Chairperson Dr. Narayanan, past State President and past HOD of Pediatrics, Samana Medical College and Medical College Thrissur, Bharti Madam, Dr. Professor Komlavali Madam, and also, of course, our today's chief guest, Dr. Srinivasan sir, other senior members of the IAP Thrissur, and also all the pediatric colleagues of the state and outside. And so at the outset, I would like to congratulate Dr. Reddy Shandagama and her team for the varieties of program they are arranging. I think 2 weeks back, we had a clinical case presentation. Of course, we had an academic program also last week by Abesha. And I think next week again, we are planning to have some children's roles in the week's observation. So Reddy is coming with different varieties of program. And as such in Thrissur, there are 4 teaching institutions, including 3 medical colleges and a mother hospital. And of course, in this COVID season, lack of case presentation is a very major handicap for the PG students. So I think to an extent, we can overcome this problem. As I think my request to all PG students are to make make some pictures for a clinical demonstrating clinical skills, just like our bar session, so that it will be useful other PG students also. Anyway, we are lucky to have a great teacher, Dr. Srinivasan sir. When Srijit asked me whom to invite for the first program, then we have not doubt to it's none other than Dr. Srinivasan sir, the great teacher. And I wish
You are making me nervous.
I wish the program all the success, and hope that it will go uninterrupted. Even after somebody mentioned, even after post-COVID season also, we'll continue the same program. And I officially declare the program is inaugurated. Thank you. Jai Hind.
Thank you, Dr. Anandakeshwan, sir.
Please, PK Parathi madam.
Next is
PK Parathi madam.
Good evening to all. Dr. Narayanan, IAP State President, Dr. Edi Shantakumar, President IAP Thrissur, Vice President Central IAP, Dr. Anandakeshwan, Professor Dr. Srinivasan, sir. And it is very heartening to know that IAP Thrissur joins with teaching institutions of Thrissur for a new academic venture with bi-weekly case discussions. It will be a boon to the postgraduate students and practicing pediatricians during this COVID season. And the first session is being chaired by none other than Dr. S. Srinivasan, who is a teacher of teachers and an astute clinician. I wish the venture all success. Thank you, Reddy, for all the programs.
Thank you, madam. Next, we have felicitation by Dr. Mukesh KR, Vice President-elect IAP State. Dr. Mukesh.
Madam, Dr. Mukesh sir, due to some technical issues, Dr. Mukesh sir hasn't joined now.
Okay, so now we come to the the crux of the session, that is the teaching session. I invite Professor Dr. Srinivas, former HOD Pediatrics, JIPMER, to start the session, sir.
Thank you so much. Yeah. So it is, of course, you all made me nervous by saying teacher of teachers, and you also told that your young teachers, they can watch me. So you will understand that if Srinivasan can be called teacher of teachers, then it will be easy for all of you to become masters in this profession. Okay, that confidence you will get after my discussion with Dr. Shalu. And that I have taken permission of Anand Keshavan that I will be asking questions more to the other PGs, and he has given certain list of names which I am having, because Shalu, I'm sure she knows the case and she must have prepared. Okay, and usually whenever I take PG classes for exam going PGs in various places, so I give freedom, I don't trouble the person who is volunteering to present. Already she has taken the courage to present, so I will not put her in a place of, as if judge is asking questions to the client. Okay, so I will be addressing the questions to other people, because I hope now Wilbina, they have switched off, so they will be watching the match. So to keep their interest in the case, so they must be alert. So I have taken Ananta Keshav's permission, because today being a match day, so we don't know after switching off the TV and then video, what they are doing, we don't know. So to keep them, I am having the list. I will ask the questions, and later she will answer. Shalu will answer. Dr. Narayanan, you agree with that? Yeah. Okay. Now, without wasting your time. Yeah. Without wasting time, I will ask Shalu. Shalu has, of course, first slide I had made a correction when she sent to me. So she has given the diagnosis in the first slide itself. Of course, it's not a difficult case to know what is the diagnosis. Okay. But then, and another important thing I want to mention here, okay, to all the pages, never say I am presenting a case. I can understand a lawyer presenting his client's case in front of judges. But we doctors should not treat, as Hutchison says in his quotation, never treat a child as a case. Okay, a child, how many months old you can mention, a 6-month-old infant with this problem, okay, with a complaint. Don't straight away give the diagnosis, then the interest of all the other pages will be coming down. So that is the correction I made. With that, we'll start. You agree, all of you, that we don't like to call a child as a case of so and so, etc. Yes. Now, with that introduction, Dr. Shalu will be now free to present her case. Yeah.
Yes, sir.
Shall I? Yeah.
I'll start the screen share. Sir.
Yeah.
Okay, sir. I hope it's visible.
Yeah, it's visible.
Respected teachers and my dear friends, today I'll be presenting a case.
Not case, presenting a child.
Child, Adi, from Otubara, who was born on 4th May 2020, who came with a complaint of rapidly increasing head size noted by mother over last 1 month, and informant is mother and information is reliable.
Okay, at this stage I can ask questions. So I'll ask questions to Kirti. So she has mentioned that mother says child is rapidly increasing head circumference noted from 5th month onwards. So will you give what is the probable causes of a child having rapid enlargement of the head? Is Kirti there?
Yes, sir, I'm here.
Can you please tell what will you think of?
Either maybe hydrocephalus.
Very good.
Then any increase in the subdural space,
all
like
possible. So whenever you are asked to talk about, you talk about this thing, infections. You know how to think of causes. Nutritional. What nutritional you will think of for increasing head size suddenly?
Rickets. Vitamin D deficiency.
Very good, very good. Okay, fine. Next. Then anything? Naturally, you have to think of infections.
Infections like meningitis,
common.
subdural effusion.
Okay, very good.
Subdural empyema.
Either
increase in the brain
tumor,
cells.
any tumor?
Yes, any tumor, malignancy, any metabolic disorders causing increase in head size, like
very good, very good.
Degenerative disorders like Canavan's disease, Alexander's disease.
Okay, very good.
Gray matter disorders like Tay-Sachs.
Very good.
Or any metabolic disorders.
Mucolipidosis, so many things are
GM1
there.
gangliosidosis.
Okay, I'll ask this girl. Okay, Sherin. Okay, Sherin, tell me another metabolic condition which is, which is type 1, type 2, one particular this thing. Which one causes liver problem as well as macrocephaly? So it's an intestinal problem. Starting in G. Type 1.
Type 1 glutaric acid.
Very good, very good. Yeah. Okay. So now we'll go to the next slide. Of course, she will be later telling all the
liver and head.
Yeah. So Shalu will be telling all the causes of macrocephaly later. We'll proceed with the case. Shall we? Next slide, please.
As there is significant perinatal history, I would like to start from the antenatal period. Adi is the second child of non-consanguineous marriage, born to 24-year-old mother and 29-year-old father. After the birth of first child, who is a 5-year-old girl child, born via full-term vaginal delivery, 2.7 kg was the birth weight. The child is having normal development and growth. And there has been no history of abortions and no history of infertility treatment. Coming to the details of antenatal.
I will ask this thing. Syed Bakri, so will you please tell why she has asked that particular history? No history of infertility treatment. What is the relationship of infertility treatment with
Sir, because like due to like very like in fertility treatment, like chance of congenital abnormalities will be more.
Yeah, infertility treatment is supposed to be associated with clomiphene, etc., neural tube defects. Okay. Similarly, of
It's like
course,
clinical
it's
result.
yeah. So infertility, and you must also mention about this thing, folic acid deficiency. Okay, so no infertility whether the child has taken regular folic acid, because you are talking about a child with increasing head. Okay, so you have to be think. Now let's go to the next slide. Yeah.
So coming to the details of antenatal checkup, pre-pregnancy weight of the mother was 45 kg. First
Why
trimester
somebody
details,
is, I think, there is
she
an
was been
echo.
under regular antenatal checkup.
There is some echo behind. All of you, please mute. Yes. Once you finish answering, you please mute your this thing. Only when answering, you open it. Yes.
PG student, only limited PG students unmute. Otherwise, please keep it mute. Limited PG students.
Only when you answer, you open it. Yes.
Yeah.
Proceed.
And there has been no history of fever with rash, no history of any urinary tract infection, no history of bleeding PV, no history of any drug intake, and mother has received 2 doses of tetanus toxoid, and folic acid tablets have been taken by the mother.
So she has
And
mentioned
antenatal
about
USG,
folic acid. Yeah, that she has been having. Yes.
and antenatal USG at first trimester was within the normal limits. Coming to the second trimester details, quickening was felt at fourth month, and fetal movements were perceived well. There has been no history of gestational hypertension, gestational diabetes mellitus, no history of any leaking PV, bleeding PV, no history of any hypothyroidism. Anomaly scan was done and was within normal limits.
Yeah. Just to keep the slide, I'll ask Renu to comment about that second trimester, importance of each of the things he has mentioned. Is Renu there?
Yes.
Yeah, please tell about the second trimester. First trimester, she has mentioned no history of drug intake. Naturally, that has been ruled out. No infections. Okay, now coming to the second trimester, what is the information which is she has given? Shalu has tried to tell us about this child. Renu is there? Or Kirti again? Renu Sundaresan, please
Answer.
unmute. See, what is the information? After all, every slide has some
The
information.
antenatal.
So quickening means child is not having limb movements are normal. Limb movements are normal, isn't it? Quickening. Okay, fourth month. It is too early for your primary, but it is a second child.
Second child.
Okay, so naturally fourth month is normal. That means the movement of the child is normal. Okay.
Yes.
So that indirectly gives us that lower limbs are not weak. Okay, hypotonia is not there. Then what about the next one? Fetal movements perceived well. No history of gestational hypertension. Yeah, previous slide itself. Yeah. No history of bleeding and leaking. PV anomaly scan within normal limits. Very important. So they have done scan specifically for anomaly. So it is normal limits. So what does it mean?
Antenatal detection of any
Neural
fetal
So there is no fetal.
can be made out.
There is no fetal
Fetal defects have
hydrocephalus.
been ruled out, sir.
Okay, no fetal hydrocephalus, because we understand, because it's a Kerala patient, so people are very careful because litigation rate is very high because all are educated, so they are all aware of everything happening, so they will be very careful in giving report that anomaly scan. Normal limit means they must be 100% certain because of this problem. That means this case doesn't have fetal problem. Okay, so child is moving the limbs well. Child is this thing having normal scan. They haven't found anything abnormal. Okay,
Yes,
we
sir.
can take it as a correct report. Yes, next slide, please.
Coming to the third trimester, mother reported complaint of oligoamnios at 6 months, for which she received IV fluids and medications. And in subsequent scans, amniotic fluid volume was said to be adequate. There is also complaint of decreased fetal movements in 7th month. At that time, USG was done, and mother was reassured that everything was within normal limits. At around 34 weeks, mother complained of rapid weight gain, complaint of pedal edema, and occasional headache. But there was no history of vomiting, seizures, or double vision. And high BP recordings was recorded, and she was started on tablet Nicardia for that. And in third trimester also, there has been no history of gestational diabetes, leaking or bleeding PV, no history of any maternal fever or UTI. Other than tablet Nicardia, we don't know that she doesn't give any history of any other drug consumption.
Clues are there, okay, which rules out certain problems. Okay, so child of course had some decreased movements and oligohydramnios was present, but then it was found to be normal. The obstetrician and the ultrasonologist has mentioned that everything is all right, you need not get worried. Okay, so that means there is reassurance that there is nothing wrong at that period. And you can see that child became again active. Okay, the fetal movements have again perceived well, but then mother developed a problem. What is the problem? Fetal edema, occasional headache, high BP, and yes, no issue vomiting,
Hypertension,
seizures. So pre-eclamptic,
preeclampsia.
pre-eclampsia had. Okay, yes, okay, but nothing has been mentioned about the urine examination or this thing. Okay,
There was no history of UTI, sir.
no, no, no.
But we don't know the urine
Albumin,
examination
yeah,
of the mother
yeah,
relating to
yeah,
preeclampsia.
yeah. Whether they told uppunir, in Tamil they say no, whether salt, albumin, they say uppur. So that means you'll know that mother had pre-eclamptic toxemia certainly, but of course she had a problem, antenatal problem, but otherwise nothing to suggest an infection as a possible cause of enlarging head later on at 5 months of age. Very good. Next.
And coming to the perinatal history, at around 34 weeks, she was referred to GMC Thrissur with a complaint of decreased fetal movements and fetal bradycardia, which was the UST done from the peripheral center showed fetal bradycardia. And she got admitted here. Repeat UST examination here showed that both fetal cardiac activity and fetal movements were good. And mother also had perceived fetal movements since then, on that day. But by around 9th that day, she had decreased fetal movements again, and USG showed fetal bradycardia, for which emergency LSCS was done.
Okay, so
And
I will just in the slide some discussion. Shall we have? So what does it tell you? Now Shalu will answer this. Am I pronouncing your name correctly? Shalu or Shalu? Yeah. Whatever the way I want. Okay, tell me. So what do you think? A child who has been fetus who has been behaving normally suddenly has started behaving erratically. So
some indication of
antenatal
depression, perinatal depression is already there, sir. Some amount of
yeah, decreased movements, then
fetal bradycardia, severe
bradycardia. So when a child is having bradycardia with decreased fetal movements, okay, what does it suggest? From this point of view, from the case point of view, enlarging head later on. Though, of course, the ultrasound hasn't shown anything earlier. Okay, what does it inform you now?
That the child is having some
bradycardia means what in relation to neurological problem? You said you are having an enlarging head. What does it mean? Which causes bradycardia?
Any rapid increase in CSF,
CSF pressure increase,
can cause.
Yeah, can cause, and that can also cause decreased movements. Okay, yes, thank you. That is one point. Of course, it can mean fetal distress. Okay, yes, next proceed.
So you can add two more students, sir. I can ask question to Dr. Samiha, Dr. Amal Sashidharan.
Okay, Sangeeta and Amal Sashidharan.
Samiha and Amal Sashidharan.
Okay, Samiha is already there.
Yeah, Samiha is there. Amal Sashidharan.
Okay, fine. Thank you. They don't mind, no? They don't mind me asking questions? Okay, just to keep their attention in the slides.
Yeah.
Okay, yes. Next.
Coming to immediate natal details, birth weight of the child was 1.905 kg, which was appropriate for the gestational age.
So you have plotted it and
not cry soon after birth.
No, you have plotted it and found it to be appropriate in the chart. What chart you use?
Yes, sir. In Penton's chart, sir.
Okay,
Penton's chart, sir.
You mentioned that using Penton's chart I have come to this conclusion that it is appropriate for the
Okay.
yeah.
Sentence
Next.
starts. Okay.
Yeah. Next.
The baby did not cry soon after birth and required resuscitation. According to the details available to us, bag and mask ventilation was given for 3 cycles, and Apgar was 1 minute. 1 minute Apgar was 5, and 5 minute Apgar was 7. And vitamin K was administered to the child, and child had respiratory distress soon after birth, which required an ICU admission, and CPAP was given since CPAP was given till 12 hours of life. But after 12 hours of sorts of apnea and hemodynamic instability, which required mechanical ventilation and inotrope support. Sir, you are...
Yeah, please tell what is the, see, birth weight you already mentioned. Okay, Fenton's chart, it is appropriate for the particular gestational age. Did not cry soon after birth, okay, is probably indicative of impending hypo, this thing, okay. And resuscitation was needed. But 3 cycles of this thing, bag mask ventilation child, what does that mean? It's not that severe depression. Okay,
child did not require immediate postnatal period. Child did not require ventilation, sir. Only after
you interpret Apgar score, very important. See, child was having at 1 minute 5 is not bad. Okay, 1 minute more than 4 itself is expected in many children. Okay, and then at this thing 5 minutes it has become 7.
7.
So that means it's not severe or moderate hypoxia. Okay, so this is the information you get. Okay, understand that?
Yes,
okay, yes, next.
But on day 1 itself, child had recurrent apnea and poor sensorium was poor, sir, and required mechanical ventilation and inotrope support. And on subsequent investigation, sepsis...
So inotropic support has been necessitated. That means what?
Yes, sir. Yes, sir.
Child has probably low blood pressure. Okay, low blood pressure is not due to severe hypoxia. So what could be the other cause of low blood pressure?
There may be some other...
what could be the other cause?
It can be IVH,
in a premature child. Premature child, 3 important causes of mortality is, I'll ask Amal. So what are the 3 important causes of preterm mortality?
Sir, sepsis.
Asphyxia is not a very important cause because they get
sepsis.
Yes, sepsis.
RDS.
Intraventricular RDS is no longer, yes. Hypoglycemia, okay, uncorrected hypoglycemia. Then intraventricular hemorrhage you have mentioned, and hypothermia. These are the 3 important causes you have to always think of. Okay, yes.
And child was started on IV antibiotics. And
so in this, I wanted to point out in the previous slide, the child had mild asphyxia but could be resuscitated by bag and mask this thing. But subsequently, again, child had problem and child had gone into shock. So there's a possibility of the child having a hemorrhage. Okay, you understand that? Okay.
Sir.
Yes, because that is the commonest cause in this thing, capillary fragility and then bleeding possibility. Yes, there's a precipitating factor. Yes.
Lumbar puncture showed blood stain CSF.
Okay, already corroborated and confirmed it by LP. Yes.
And bedside neurosonogram was done, which showed grade 4 IVH.
Okay, so you already given the correct diagnosis. So before doing LP, they should have done ultrasonogram. That should come first. People will not like to do LP just like that, Now, if you had mentioned that already 4 ultrasound is there, then LP done. That means we can correlate. Otherwise, we can think it may be traumatic LP. So that order you have to change. Okay, because nobody will try to do LP without this thing, ultrasound when it's possible to do in a small child when fontanelle is open. Yes, next.
Child was extubated on postnatal day 4 and OG feeds were started and it was advanced slowly. There is no history of any recorded hypoglycemia, hypocalcemia, history of neonatal jaundice without any incompatibility, and phototherapy was given for 2 days. No history of any other bleeding manifestation was present.
Good. Okay.
On coming to postnatal day 7, child had recurrent episodes of
seizures.
So
far, the story is a child was born preterm with a mild birth asphyxia, resuscitated with bag and mask with 3 cycles. subsequently child had a problem and went into needing inotrope support and ventilatory support. Yeah, and then of course child had evidence of intraventricular hemorrhage as seen by ultrasound. Okay, fine. Proceed.
And on postnatal day 7, child had recurrent episodes of seizures and IV anti-epileptics were loaded, and child was mechanically ventilated again. And in view of increasing ventricular volume, ventricular index, and we did a neurosurgery consultation, and external ventricular drainage was done, and child also had culture-proven sepsis. Again, child was extubated on postnatal day 13, weaned off to room air on postnatal day 15. In view of increasing ventricular size, serial LPs were done for the child.
Okay, yes, so child is having definitive problem developing. Okay, so serial this thing was done.
LPs was done.
Days of yes. Okay. Proceed.
During hospital stay, DBF was started after 1 month. Actually, in the first month itself, child had occasional feeding tolerance and was kept NPO.
Yeah, child was discharged from the hospital.
No, sir, child was still admitted.
Okay,
no,
fine.
No, sir.
Okay.
No, child was in the hospital itself, and DBF was started after 1 month. In view we required a VP shunt in view of increasing ventricular size on postnatal day 47. Post-operative period was uneventful, and child was registered under high-risk clinic and advised physiotherapy. Child was discharged. Baby was discharged on postnatal day 54. Weight at discharge was 2.2 kg, and was discharged on Levipil and oral supplements.
Okay, so the weight gain is good for this period. You have plotted?
I haven't plotted, sir.
Okay, because the serial weighing is there, so you should find out whether in spite of all these problems, child is gaining. Growth is important, isn't it? Yeah. Okay, proceed.
And at home, baby was feeding well, and mother noticed that the child was alert to sound, but he was not fixing or following.
But what is missing? I will ask person. So you mentioned about the weight, but at the time of discharge, what should have been entered in the case sheet?
Head circumference at discharge was 37 centimeters, sir.
Yeah, that is important. So you haven't mentioned that. Okay. So because later you are going to tell a history of sudden onset of enlarging head, isn't it? So here, of course, you have mentioned about weight, but what is more important from this child's point of view, along with weight, is circumference. So if it has been recorded, you should have mentioned it. Okay, yes.
And at home, baby was active and feeding well. Baby was alert to sound, but not fixing and following. And baby did not act social smile. And the mother also noticed that there was increased response to sounds, but there was no history of
so please always give your interpretation. See, when you are analyzing, just because the examiner need not ask the question. So every slide has some information, and then try to infer what it is and tell. Instead of me asking every time the other pages. So tell me now, what do you think? The child is having probably visual problem.
Yes, sir. Some visual problem that was for the increased response to sounds and increased.
Yeah. So a startled response type of this thing phenomenon is there. Alert. Okay then. But child is feeding well. Okay, that is very important.
But feeding well.
Yeah.
And there is no history of any.
Which cranial nerves are normal when the child is feeding well? All the lower cranial nerves. Okay. Yeah. From the sucking onwards. Yeah. So 52 lower cranial nerves are normal. Yes. Okay. Proceed. Because child is not having regurgitation.
And there is no history of any facial deviation.
Yeah. Okay. There is no regurgitation. There is no aspiration. Okay. Proceed.
And there was no further seizures and abnormal movements. So we know that the cranial nerve parties, lower cranial nerves are normal.
Yes, but some other one cranial nerve is abnormal. Which cranial nerve is abnormal from your previous slide?
Second, sir.
Okay, second. You said visual. This thing is problem is there. Yes, good.
At around 3 months, mother noticed that there was increased resistance while doing physiotherapy and complained of difficulty in changing diapers. Now history of any scissoring of legs. Child was on regular follow-up at high-risk clinic An ophthalmology consultation during this time revealed that some visual problem was there, and child was having adequate weight gain at immunization visit. Baby was feeding well.
Yeah. So you
And
have
currently,
mentioned. Please go to the previous slide. Yeah. You have mentioned no scissoring, but there is increased
mother had
resistance.
noticed as
Tone is increased. Okay.
tone is increased.
And
Tone is on the highest
some
side.
adductor spasm is there because diapers
Some
this
amount
thing.
of adductor spasm
Okay.
is there.
Yes.
Sir.
But then one more.
And the consultation also showed some visual defect, visual problem, sir.
Yeah. That's. But one more problem is there. No. You what question you will ask? I will ask somebody else. Okay. So, Samiha, please answer. What will you specifically look for in the upper limbs? She mentioned about the lower limbs, but upper limbs, what will you look for in a child? Samiha, are you there?
So persistent of cortical palmar.
Yeah, you are answering, but I wanted Samiha to tell. Okay, the child was keeping the thumb inside the fingers or like this, or child has this thing opened it.
Initially, child was keeping the thumb here
no,
like
that if you had added no, it will be very nice. That
yes,
beyond 2 months the child is having of course the child is a preterm child, full term child it's applicable, but you can give 1 month allowance for a preterm child. Okay, but still you have to see for that. Okay, yes, proceed.
And currently, child has complained of increased head circumference, head size over last month, 1 month, and there has been no history of fever, no history of seizures, no history of vomiting or vacant stare, no history of any abnormal eye movements. Child has been feeding well. There is no history of any altered sensorium, no history of breathing difficulty, and there is no history of any noisy breathing. So, though there is an increase in head size, we do not have any other features of raised ICP features, sir.
No, I will ask now the full diagnosis so far. From whatever you have heard so far, I would like to give the full diagnosis till now. I will ask Sherin, kindly tell the diagnosis of this child. Okay, she has given such a wonderful history, and also she has given some important facets of the case, and you must be able to come to a definitive diagnosis at this stage. So, the problem is mother has noticed increasing head circumference from 5th month onwards. Okay, please now tell the complete diagnosis. Because from the history you can give 60% diagnosis. Okay, if proper history is taken. Okay, yes. She has given a good history. Yes, a preterm child, born preterm.
Child,
yeah.
With post
What
hemorrhage.
type of preterm? It's late preterm.
Late preterm.
Yes.
Late preterm with post hemorrhagic hydrocephalus.
Yeah, definitely. Hemorrhage has been documented with fluid, CSF having blood discharge, and then of course it has been proved by so that there was definitive history. Yes. Was there sepsis? Sepsis also was proved. There was neonatal sepsis also. She has mentioned no blood culture was positive for sepsis. Yeah, you have to add that also. There was some, but it was not meningitis. Okay, it was only hemorrhage. Yes. Otherwise, meningitis is also the important cause of hydrocephalus. Yes. Next.
For which the corrective surgery is also done.
Yes.
And
with the shunt.
With complication of visual abnormal.
Yeah, already having some neurological problems like visual impairment and
hypertonia,
then some evidence of motor disturbances. Okay. Upper motor neuron type of disturbances. Very good. Yes. Okay. Yes. Now, what about the growth? Sir, apart from this thing, head circumference, what about the length and weight of the child? Was the child having
sir, adequate child was found to have adequate weight gain and length at immunization visits, sir.
Yeah, that's what I was trying to ask. Okay, so there is except for the head circumference, there is not much of difference in the other parameters, length and the baby as well as this thing that she'll be telling later. Yes, proceed.
Coming to the developmental history of the child, gross motor. Child has not attained head control, and rollover has not been attained. Language social, child
I think I'll
is,
mute. I think there is echo.
there's no social smile. Child is not fixing and following. And child is responsive to sounds and he makes cooing sounds. Fine motor, he doesn't reach out to objects. So from this, hello, sir, you are muted, sir. So you are
Here
muted.
the child is saying vocalization as well as some sound response, but there is no startle response, not the exaggerated response. Okay, that you cannot know from the history. Yes. Okay, does not reach out. Why you are asking for reach out for objects when the child has not got this thing?
Yes,
So you
visual
cannot
problem.
Yeah. Okay. So you must not have this thing. When the child you say you are not able to see, and this inappropriate, isn't it? And moreover, even the earlier ones are not this thing. So you need not talk about fine motor milestone. Okay. Yes. Proceed.
Immunization is up to age as per national immunization schedule, and there is no history of any adverse events following immunization. Diet history. In the perinatal period, child was taken started on orogastric feeds on postnatally 4, slowly advanced, complained of occasional feed intolerance for which baby was kept nipper oral, and direct breastfeeds were completely established after 1 month, and complementary feeds are not yet started.
Okay, this slide, it's the same feeding. Please show the slide. You are from Kerala. Okay, Ernakulam is the first baby friendly area, district, and Elizabeth is the eminent nutritionist, pediatric, internationally known. So I cannot skip this slide. Okay, so you have mentioned that child is breastfed. But what about oral nurture? Is express breast milk was given or artificial feeds are given? See, I mentioned first sentence, orogastric tube feeds on this thing. So most of the mothers now preterms and all, they nowadays give express breast milk. That you didn't ask, obviously. You're not very sure.
Yes, sir. Mother was told to express feeds on postnatal day.
Because nowadays,
mother was told to express feeds on postnatal day 2 weeks.
Nowadays most of the nurseries, whatever, whether a child is having sepsis or recurring enterocolitis, mild type, they give express breast milk by tube so that the child will have some neurotropic and other factors, especially nowadays microbiome is important for minimizing the damage and improve the brain development. So that you have to mention, because you have mentioned later about the breastfeeds, but that particular crucial period, whether people are careful enough to express the breast milk and give to the child through the tube. Okay,
yes, sir. Mother was asked to express, sir. Okay. And currently child is on exclusive breastfeed, sir.
Yeah, fine, proceed.
Family history. There is no history of any developmental delays.
No. Wait, you don't this thing. So I will ask some question. Please show this thing, pedigree chart. Pedigree chart, please. Pedigree chart. Go to pedigree chart. Yeah, I will ask one of the PGs. PG. Shall I ask Kirti again? Kirti, are you prepared to answer? So what does this show? How many generations she has shown in this?
She has shown three generations.
Is there any consanguineous marriage in any of them?
No consanguineous marriage. There is
what type of genetic disorder can be this thing? Unlikely in this case. Because there is hardly any other child we are having this problem, isn't it?
Yes, sir.
Okay, so there is no consanguinity, so autosomal recessive is not there. Is there autosomal dominant?
No, sir.
No, there is no
autosomal dominant. All the generations will be affected.
Okay, X-linked?
X-linked, in X-linked there will be male child.
There is no. You can see that none of the males are affected. Okay, there is nobody who has been involved and there is no consanguineous marriage. So it's not due to a hereditary problem. Though we have found that is a hemorrhage, okay, earlier. But there could be two problems, isn't it, together? Child may be predisposed to this thing, so you must try to understand. Because most of the important cause of hydrocephalus is genetic in origin. Here, though there is a history of definitive hemorrhage and preterm causing hydrocephalus, but don't forget to put the pedigree chart. There can be more than one factor operating. Okay, and must be able to interpret each and every information you are giving. Next one. Thank you. Proceed further.
Coming to the socioeconomic status, father has studied up to 10th standard and is working in an interior designing company. Salary of 30,000 per minute. Mother, fashion designing diploma after 10th standard. 6 people at home. Concrete house with 4 rooms plus kitchen with attached bathroom. Water source is borewell. And according to modified Kuppuswamy scale, latest Kuppuswamy scale of 2020, they belong to the lower middle class.
So what is the information you gain from? Hey, please don't run away. Very important. So father is how many? They think 10 standard. Okay, in designing company. So what is the salary? Salary per month?
30,000.
30,000. What is the salary of a MBBS postgraduate? How much as a junior resident you are getting? Third year junior resident. Huh?
Yeah, 60,000, sir.
60,000, not bad. Okay, good, not bad. Previously, there are some places where still they get less than 15,000 and 20,000. Okay, your state is a rich state, so good. Okay, this is just to lighten the moment, seriousness of the situation. Okay, yeah, proceed. No, you must understand. So in Kerala, even 10th standard can, if they work hard, they can earn that much of money. That's good. Yes.
And this is just a for modified.
Kuppuswamy is recently updated, sir. Kuppuswamy.
This is 2020, sir.
2020.
How many more minutes, doctor? So accordingly, we have to speed up things.
Yeah, you have to speed up, sir. Otherwise, we have to complete.
Yeah, sure. Okay, yeah.
Chalo.
Sir, I'll move on, sir.
Chalo, aage chalo.
Coming to general examination, baby is awake, alert to febrile, vitals, pulse rate of 110 per minute, normal rhythm, normal volume, peripheral pulses were well felt, respiratory rate of 40 per minute, normal work of breathing, BP 80/60 in right upper limb, SpO2 of 98% in right upper limb, no cyanosis, no clubbing or edema.
Can you tell about the child's photograph? You see the photograph and describe the child's position, posture. Syed Bakri, please see the.
Hello, sir.
Hello. See the child's position. No, she has taken a nice photograph. Please comment about the photograph. So, what is the child? Child is having the head in the midline. It's not either turned to the right or left. If the child's head is turned to the right or left, then we can say child is having asymmetric tonic neck reflex. But child is keeping the head in the central position. So what do you think about this thing? Hand. Which tone is increased? It's not hypotonia, isn't it? Child, hypotonia means it will be floppy and lying like a frog-like. This child is having flexor tone increased. And what about the thumb position? Thumb is inside, okay? And then, of course, the child is having no adductor spasm. It's slightly abducted and flexed at the knees and also dorsiflexion. So, you must be able to appreciate everything. Okay, yes, that is very important. Otherwise, the growth nutrition seems to be fairly all right for that particular age, from the face, etc., and the muscle. Yes, proceed. Proceed. Next slide. Yeah, got stuck up?
Yes, sir. 1 minute, sir. Yes, sir. Coming to head to foot examination, head appears large. The surgical scars over scalp in the bilateral parietal area. Anterior frontal measures 4 × 4 cm and it's not bulging and there's no bruising. Posterior frontal is not palpable, sir. And sutures, there is mild sutures.
Okay, yeah, proceed.
Frontal prominence present, dilated veins are present over the forehead. and baby is having persistent downward gaze. There is no cataract. This fundus examination showed bilateral pale disc without any cherry spots or evidence of chorioretinitis, which helps us to rule out chorioretinitis without intrauterine infections like toxoplasma. Can you move on?
No. The previous slide. Yeah. I want to one of the PGs to tell. She has mentioned antefontanal, not bulging, no bruit, then posterior fontanel. But in a child who is having hydrocephalus, okay, sometimes the whole this thing will be open, so you cannot separately. So here it's not this thing. There is a suture. So separately you can feel the antefontanel. Is it? Hello?
Yes, sir. Yes, sir.
Yeah, okay, fine. That means the child's no, bones are united. Okay, it's not such a severe hydrocephalus. Okay, proceed. Because of the shunt surgery. Good. That's indirect indication of shunt working well. Okay, otherwise child will be having complete separation of this sagittal suture. Okay, yes. Okay, proceed.
And coming to other, there was no other facial dysmorphism. So in coming to facial dysmorphism, there is no history of there was no post facies, no depressed nasal bridge, no protruding tongue, hypertelorism, corneal clouding, and this helps us to rule out possibility of Hurler's disease. No maxillary hypoplasia, gingival hypertrophy, and cranial stenosis to rule out Apert syndrome. There was no blue sclera.
No, this one shows that there is hardly any conditions to think of syndromic conditions.
Any other
already from the chart, the pedigree chart we have mentioned, there are no autosomal recessive, autosomal dominant or X-linked causes of this thing. Okay, hydrocephalus or microcephaly. Here you have mentioned that there are no dysmorphic phases or other malformations. That means some syndromes. There are so many syndromes which are not there in this child. Okay, yes, proceed. Next. We'll tell you that you are already having the causes, later we can tell the causes. Oh, okay, yes.
Ear is normal and there is no ear discharge. Palmar crease is normal. There is no disproportionate shortening of limbs. There is no digital anomalies, no polydactyly or syndactyly. Chest wall shape is normal. No neurocutaneous markers. Spine, there is no evidence of any neural tube defects. Genitalia is normal. Our hernial orifices are free. There are no skin or mucosal joint bleeds. No callosities or bed sores, no evidence of any micronutrient deficiencies.
Yeah, yes. So it is only post-hemorrhagic hydrocephalus and there is no other syndromic or genetic cause for this child having hydrocephalus. Okay, yes, thank you. Yes, proceed further.
Coming to the anthropometry, I've compared the weighted at birth, weight was 1.9 kg, which was appropriate for gestation age. Head circumference was 34. At discharge, head circumference was 37, sir. And currently, weight of the child is 6.5 kg, which is according to the WHO growth chart, which comes between the first -1 to -2 standard deviation. Length is 65, which is again in the -1 to -2 standard deviation. Head circumference is highly elevated increase, that is in the 4th standard deviation.
Okay,
weight for height is in the -2 standard deviation.
So what is the interpretation? What is the interpretation? So the child is not having height and weight, this length and weight involvement.
Height and weight is normal.
Yeah.
Only head.
So why I am asking this question? Why I am asking this question? You can answer or any other PG can answer. See, any child who is having hydrocephalus can have.
Has been improper and.
No. One is feeding.
Improper feeding has been.
Sir. Yeah, here the feeding is proper. Wasting. Nutrition is normal, but from the central nervous system point of view. See, after all, you know that there is the hydrocephalus. So there can be pressure on the hypothalamus and the child can have growth hormone. Deficiency, etc. So naturally here the child is having length is normal, etc. Okay, and the child is having neither So it's very important because some of these children can have evidences of already you may have some evidences of growth hormone deficiency. Yes, proceed. Yes, next.
Coming to nervous system examination, baby is awake, allowed to sound and moving all four limbs. Cranial nerve examination. Second cranial nerve, child is not fixing and following. Pupils are equal and reactive on the to light on the both side. Menace
Very important. Very important. Child is having
perception.
Perception of light. Okay. Usually in these children they have accommodation. Okay. What is that sign known as? In a child who is having sunset signs, but child is having accommodation, but light is not perceived. What is that condition? What is it called? Collier sign. What is Collier sign? You have heard of it? So when the child, you have, child is having sunset sign, child is looking down, but when you ask the child to look up or take the something so that child can see, so they'll have indrolling of the eyeballs. Okay, that is yeah, Collier sign. Okay, yes, yeah.
And fundus examination shows bilateral pale disc. 346, no, there is no ptosis. External movements. So child is having persistent downward gaze, sir.
Yeah. So the child is not looking up at any time.
Jaw jerk is.
Child was not looking up at any time.
Sir.
Okay. So if the child is an older child, of course you will have. Yeah, good. So sunset sign is there. Where is the lesion? We will ask somebody else. Please ask one of your colleagues to answer. Sunset sign, where is the lesion?
The tectal level.
Yeah. So pressure on the
mesencephalic
tectum. Yeah, mesencephalic area of the midbrain. Good. Next. Proceed.
Fifth, jaw jerk is absent and sucking is normal. Coming to 7th cranial nerve, there is no facial deviation, no nasolabial folds are normal. There is no drooling of saliva or milk, and 8th cranial nerve is present. 12th nerve is no atrophy or deviation or fasciculations of a tongue, sir. So you muted, sir.
Proceed.
Motor system examination.
Which cranial nerve is involved? Which cranial nerve is involved?
So from this we can understand that the second cranial nerve is involved, sir.
Vision is involved. Yes. Next.
And motor system examination. Bulk of bilateral upper limb and lower limb is bilaterally symmetrical, and there is no any hyper increased muscle bulk, which may be seen in hypertonia.
But tone, of course, is increased. Yeah. So when you are saying tone, you must say flexor tone or extensor tone, adductor tone or abductor tone. You have seen the position of the child. No, adductor tone is not increased.
Adductor tone, no, but flexor tone of upper limbs.
Yeah. So abductor tone is increased and flexor tone is increased. So you must be able to tell, no? Yeah. Yes, proceed.
Amial tensile angles examination. Scarf sign, elbow distant post midline. Adductor angle.
No. The child is beyond that this neonatal period. We need not mention that this thing, Yeah. So if it's still in the neonatal period, you can mention that. Okay, but of course, this child is having already increased tone and neurological damage, so you need not have to mention that. Yes, proceed.
Power is child is actually moving all four limbs, so it's definitely greater than.
But in no time the child had convulsions from the history or from your examination.
Yes, sir. During neonatal period there was convulsions, sir, and but there was no
after
other
that,
convulsions.
Of course, you mentioned the child was on 2 anticonvulsants. So after that, you have to mention that, okay? Because in the final diagnosis, you have to mention no convulsions, no this thing. Yes. Now you tell about the child's position. Child is looking at looking towards the left side, and what happened to the hand? Which this thing? What happened to the extensor tone is increased, no, the left hand. So now the child is turned to the other side. So which reflex is asymmetric tonic reflex is present still. Yeah.
Asymmetric tonic reflex is present.
Okay. Next, yes. Proceed.
Coming to the reflexes, sir. Superficial reflexes was normal. Plantar reflex was extensor. Deep tendon reflexes, Georgic was absent. Biceps was 3+, sir.
What
And
about
supinated
plantar?
jerk?
What about plantar response? Any comment, extensor? Because there is a no. So some books still mention that till 2 years of age or 1.5
extensor
years.
can be normal.
It's normal.
If no other neurological findings are there, or in either in the history or in this thing, then extensor plantar you can take it as
normal also, sir.
As normal. But if the child is already having other abnormal signs, it has to be taken seriously. Okay, yes. Proceed.
And knee jerk is brisk, sir, 3+. And ankle jerk is also brisk, sir. And there was no.
No, sir, please. I am a learner now from you. Okay, so yes, don't say so. Okay, yes. The sir business should go. Okay, yes, proceed. So what does it indicate? The child is having now, you said the second nerve, cranial nerve is involved. Okay, and then child is having evidence of pyramidal tract involvement. Okay, bilateral. Yes, proceed. Next. Yeah. And also some primitive reflexes are still present. But of course, you must also try to put the child in the prone position for what reflex? When the child is put in prone position, what will happen when you lift the head? What is that reflex called? When you lift the head of a child in prone position, what will happen to the upper limbs and what will happen to the lower limbs?
Upper limb will extend and lower limb will flex.
Symmetric tonic neck reflex. Okay. So when you extend the head, the hands will extend and the lower limbs will flex at the hip and the knees. That is how the child looks up and looks around. Okay. The opposite is abdominal reflex, tonic labyrinthine neck reflex. So when you try to extend, the child will, instead of extending, it will further flex the upper limbs and extend the lower limbs. Okay. That is an abnormal reflex. Okay. Proceed. You haven't put that the child in the prone position, try to see. Okay, it's a delicate thing. Can you hear me? It's a delicate thing to put the child in that position and then they think the mother may be objecting. But of course, it's important to see in a child. Okay, whether that's, of course, the child didn't have asymmetric tonic neck reflex itself. So it's not possible that you will be able to see, but abnormal tonic labyrinthine reflex you can see. You put the child in prone position, lift the head, and also Landau's response you must see. Okay, have you done Landau's response, ventral suspension, and see the position of the back, whether it is, yeah. Tell me.
I'll come to that.
Yeah. Good.
Neonatal reflexes, palmar grasp present, plantar grasp is also present, placing and walking reflexes present, asymptotic reflexes persistent. Cerebellar signs, there's no nystagmus, there's no signs of meningeal irritation. Examination of skull enlarged with wide AF, no groovy, transillumination is positive, spine is normal.
So transformation is positive, very good, you have done that, and spine is normal. Okay, very important thing. Okay, yes. And AP shed patency also you checked? How did you check?
Behind the ear, where there is the VP shunt tube present, we have to compress it and look for the patency of the tube.
Yeah, I would ask the PGs, do you think the ear of the child is normal? The ear seems to be a little bigger for the child.
Large.
Yeah, large when compared to slightly lower placed. Okay, otherwise there is no this thing. Is it the same on both sides? Or because of this operation it is looking like that? I just wanted to know. Okay, thank you. Yes. Proceed, good. You have done a very good job so far. Yes.
ATNR.
Yeah, you have already shown that. Yes, very good. Yeah, very good. Proceed, very good. Yes.
Coming to developmental assessment.
Yeah.
Pull to sit, complete head lag is on ventral suspension. The child can maintain the head in the same plane as rest of the body. Vertical position, there is no scissoring. Prone position, head is turned to one side and child can lift the chin, and there is intermittent flexion and extension of hip. Has plantar hand is present. Yes. And child is not following right objects. So there is head lag and
Good. Go on, go on. Very good. Child smiling. Child is responding. Yeah, child is smiling. Good. Then next one.
Other system examination.
Yes.
So cardiovascular system
All are
examination.
normal. All are normal.
Yes, sir.
Okay.
Yes, sir. There was no organomegaly also, sir.
Okay, good.
To rule out other metabolic and
okay, fine.
storage disorders.
Yes. So now can we go to the diagnosis?
Yes.
Yes.
I've just kept.
Yeah.
Sir,
so here,
so
of course, the history as well as this thing is told definitely this thing, you know. What is the diagnosis?
So
what
here from the history and examination, we have come to rule out malformations because there was no innately detected hydrocephalus or any neural tube defects.
Yes.
And there was no evidence of any genetic or chromosomal disease. There is no abnormal facial abnormality ruled out. Possibility of intrauterine infection. There's no definite history of intrauterine infection, and there's no intracranial calcifications or anything. Bleeding disorders. There's bleeding parameters of the child was normal, and child has survived 2 surgeries, 2 VP.
Yeah. So it's very important to say. No. You already mentioned. Why most probably? It's certainly post-hemorrhagic. Okay. We have found out and you have told a very good history and examination that other causes have been ruled out. Spine is normal. There is no evidence of Dandy-Walker syndrome or this thing. Okay, neither spinal deformity to find out. So why you want to just touch the nose like this? By taking the hand behind and touching. So tell straight away you come to the diagnosis. Yes.
There's no need for DD here, sir. It's straightforward case.
No, that she is, it's a straightforward case which is already mentioned and we already discussed at each and every this thing to rule out. So come to the diagnosis and tell what is the current developmental status of the child, neurodevelopmental. Yes. So not probable. Post-hemorrhagic, it has been proved and you have seen CSF is bloody and then there was of course infection but not meningitis. It's not post-meningitic. Yes. Yeah, you are having pictures, please show so that for the audience, yes.
So these are pictures of the neonatal USG scans that were done, sir.
Yeah.
There's here we can see ventricles are dilated and filled with blood, and you can also see the parenchymal bleed present.
Yeah.
This is a sagittal.
I remember in Calicut when Lulu Matthew conducted PG examination, some 7-day program, teaching program. I was asked to discuss a case of hydrocephalus, fetal hydrocephalus. What is the ultrasound criteria for fetus to diagnose hydrocephalus? You said, here the ultrasound was normal examination. How many more than how many millimeters? Yeah, if you see the lateral ventricle atrium.
Levin's index.
Yeah.
Levin's index or ventricular index.
Yeah. So what is it? Because sometimes I have seen examiners asking that.
So Levin's index is measured from the fox cerebri to the lateralmost point of the ventricles, anterior of the lateral ventricles.
And it's compared
so
to
anything more than 10 mm, and there is it's plotted according to the gestational age of the child. Usually greater than 10 mm is abnormal, and greater than Levin's index greater than 97 centile.
Okay, proceed. Good. Yeah. Kindly remember that some examiners ask this. Okay, yes. I'm telling other postgraduates. Okay, proceed.
CT brain at 9 days of age showed this IVH, intraventricular hemorrhage present with parenchymal bleeds, extensive parenchymal bleed over the parietal and occipital region with some midline shift and ventricular enlargement.
Yeah. Next. Further.
This is the CT brain that was run at admission.
Yes.
At admission this time, and it showed enlarged ventricles bilaterally And you can also see VP shunt tube in situ.
Very
in
good.
the
Very important. Yeah. Yes. Placement of the this thing is very important. Sometimes displacement will occur, so it's very important. Yes.
This is an
So from your history,
X-ray of the
I'll
bilateral
ask you one
shunt
question now.
that has been
Okay.
done.
So can I ask you a question? Hello. So from this thing, what is not present? What complications are not present so far of shunt? Child has had shunt, but what complications are not there so far? It has been done well. What do you think? What is the judgment? Can you hear me? Hello? Have I lost connection? Hello? Hello? Can you
Sir,
hear
you are
me?
audible. Yeah.
Why I'm not audible? I am.
Yes, sir,
this
you
thing,
are audible, sir.
Yeah, please tell me so that no, you already mentioned that. So what are the this thing? What about the operation? How will you say the surgeon has done a good job or not? So what complications of shunt is not present in this child so far?
There is no migration of the shunt,
Yeah,
or
there is no
intestinal
migration. There is
perforation,
no
perforation,
yeah,
pseudocyst
and
formation.
child is doing relatively well, isn't it? So child, yeah, nutrition wise, child is normal. Okay. So shunt is working perfectly. Usually there'll be problems of obstruction, etc., which is not there, isn't it? Breakage is not there, migration is not there. Okay, neither block on either sides. Okay, what are the various shunts available? What is the historical background of shunt surgery? So which all areas were used initially for surgery?
So, ventricular peritoneal.
Yes. That came
Ventricular
later,
atrial.
ventricular atrial. Why ventricular atrial has been
Ventricular
given up?
ventricular.
Why ventricular atrial?
Because there is high incidence of arrhythmias and public shunt nephritis.
No, pulmonary embolism and shunt nephritis, nephrotic syndrome, hematuria, etc. So now ventricular peritoneal shunt is preferred. Yes. And now what is the thing? Especially if the child is having aqueductal stenosis or here, of course,
Third
it's not there.
ventriculostomy.
Yeah,
Third
ventriculostomy.
ventriculostomy.
Okay, so here you must be, I'm telling, because of the time limit, I'm telling all the postgraduates must know what are the complications of a shunt. Okay, and also how to demonstrate, though the manual test is not very important, but of course, at bedside, you must be able to demonstrate in a child how to see the patency of the shunt, which you already shown this child is not having any blockage. Okay, yes. Dr. Antakeshavan, you would like to ask any question?
No, sir. I think
neurologist. Yeah, you must be able to judge the functioning of this thing and also congratulate the surgeon who has done, and the child is thriving well except for the neurological problem. So that is a good thing, which So
is
yes.
there any malnutrition? Any other? What about nutritional status? Also good.
Child has been exclusively breastfed from 1 month of age, and currently weight for age, it's up to age, sir. And child has reached 6 months, so we have to start him on complementary feeds.
So don't forget to mention about the comorbid condition like malnutrition and other problems and any other extra problems, vision, hearing problem. In this patient, I think there's no problem. Okay.
Yeah.
Okay, sir.
Yeah, now of course she's telling about the causes, etc. Okay, if the time is there, we can go ahead. Otherwise, we can tell the child is. What will you do for this child? So you just show the slides quickly so that the PGs also have an idea of this thing. So we already proved in this child there is no genetic syndromes. There is no, So all these things have been ruled out by proper examination, clinical examination. We have to give marks to her. Yes, next one.
This is hydrocephalus.
Next slide. Yeah.
Causes of hydrocephalus, various causes. There are many causes.
So, yeah. So now you show the next slide. Any of these features are present? No. So
No, sir.
we have arachnoid cyst, nothing is there. So you have mentioned no dystrophism, no this thing. So no cerebellar signs. So all these things have been ruled out. The history also you have ruled out. all the intrahepatic infection, but by fundus examination and no hepatosplenomegaly or no other comorbidities, you have ruled out that. Very good. Next.
And continuing etiology of hydrocephalus.
Yes. Yeah. So here we have identified the child had definite evidence of hemorrhage, isn't it?
Hemorrhage.
So we have shown the CT scan as well as MRI scan, etc. Okay.
So how will you grade the grading of hemorrhage IVH?
There are mainly two grading, papillae and Volpe grading system. Volpe grading system.
Type this one. I don't know the details because lack of time. In your case, in the case, what is that? Which grading? 3 or 4?
You said you have shown the picture also.
According to papillae grading, it's grade 4, and according Volpe, there is parenchymal hemorrhage. That is a special.
You already mentioned it's grade 4, isn't it? In the this thing when you mentioned about the report. Yes, good.
Coming to causes of macrocephaly, as such, there are various causes, some of which I have shown here.
Yeah, here of course you have found it's not macrocephaly because the child is already having shunt surgery, everything. So we will not consider this as important. But you must know, examiner may ask because the diagnosis is very certain in this and everything is known. So they may try to probe your knowledge about macrocephaly, other causes, etc. So be prepared to answer them. Yes, good. Next one.
Megalencephaly causes.
Yes.
Can be anatomic and metabolic. Just enlisted some of the causes.
So megalencephaly, you have two types. Okay, that is increased growth syndrome, somatic growth syndrome, and normal this thing, and various syndromes are there. It is very well given in Nelson. Kindly read. Okay, yes. Next.
Thank you.
Yeah. So the internal examiner can ask two or three questions. There are two excellent internal examiners. So whoever is interested in asking, they can ask.
Students, stop screening. Sharu, stop screen screening.
Sir, you can ask one of the other internal examiner, Parvati, to ask a question. After all, it's the examination preparation. So two external and two internal.
Yeah, Dr. V.K. Parvati, Dr. Vinod Jacob Charan is there, and Dr. Purushothaman. We go to 3 senior examiners.
So I am giving her 70% pass mark.
Okay.
Yes.
That's so much.
Yeah. No. She has done a good job. Yeah.
Purushothaman, sir?
How many days you gave for her for preparing? How many days you gave for her to prepare this?
2-3 days. 2-3 days.
Okay, yeah. Of course, in the examination, in 40 minutes, you have to get all these things. Okay. Yes. Okay, proceed.
She is very a good student and she came forward. That is why.
Yeah, very good. Yeah, she has done a good job. Yeah. Anybody else wants to ask question or we'll wind it up?
Madam, V.K. Parvati, madam.
Dr. Parvati, please, internal examiner, one question at least. You must try to bowl a googly. She has answered almost everything.
Yes.
So you are very happy? How much you are going to give her? Yeah, she is she is passing without difficulty in this case. So one long case, she is doing very well. So good. I'm sure all of you will go and read today about hydrocephalus. Nelson has given very well. Forfor has given very well. So whichever textbooks you are following, please read. And this exercise must be done. Whenever you learn something and those people who haven't read, go and read it again. Okay, then it will be there for a longer period of time in your mind.
Any points want to clarify by any students? Any students have to any points to clarify?
Yeah, they can ask any questions.
You can unmute and you can ask questions.
Anybody wants to ask any questions, or you are all eager to go and watch the remaining match?
Hello.
Yes.
Yeah, I'm Dr. Kalyani Pillai from Amala Medical College.
Yeah, very nice.
Yeah, sir. I just wanted
to introduce. You are a student or you are this thing teacher?
No, I'm a teacher.
Okay.
Yeah, please.
You can add some more information. Yes.
Yeah, I just wanted to tell them that the students that the history of shunts in India is very illustrious because shunts were very expensive to import to India.
Yeah, it is a
So
Upadhyaya.
Dr. Chabra and Dr. Hakim, two very famous shunts
No,
are
Hakim was
produced in India.
this thing, Upadhyaya shunt. Well,
and Chabra was the first
Upadhyaya
one.
was All India Institute, of course, then Hakim, then Chabra. Yes.
Hakim,
I didn't mention about the initial this thing, Holter, Spitz Holter valve, and then subsequently other valves. But to make it very, almost it came to 400 rupees Upadhyaya shunt. He was a pediatric surgeon in All India Institute. Okay.
So
And
shunts became affordable for a lot of our patients then.
Very good. Thank you, madam. It's a very, we want to talk about the history of shunts. Okay. And this shunt is functioning very well, actually. Otherwise, very costly. Yes. What is Umaya reservoir in a hydrocephalus?
A ventricular access device.
So you can, you can take in samples and try to find out. Okay, but it can also cause infections, etc. when you periodically do it. Okay. Sir, can we wind up or you want to? Thank you so much.
Over to Dr. Srijit Kumar.
So how much marks you are giving me for this? Am I passing the examination for having called me, invited me? So did I do justice for being invited as the first teacher for the PG program in Thrissur?
Yeah.
So I hope I haven't let you down. You have been so fond of me, so you have called me. I hope I have not disappointed you.
Yeah,
Madam, Parvati, madam, what do you think? Have I done justice? Okay, proceed.
So, Srijit, you can proceed.
Okay, thank you, sir. Thank you for inviting me. And first of all, I thank Dr. Srinivasan, sir, for accepting our invitation and sharing our first session of a PG academic session.
One information I want to tell, see, I wanted the summing up, never call a child as a case of so-and-so. Okay, you say, I am presenting a child with this problem. Okay, what the mother has mentioned. Okay. The second thing is I want to mention is that every slide you tell what are the things, try to find out and tell the examiner from this. Of course, you will not be presenting slide, but you will be presenting the case sheet. So you must be able to now and then give the examiner what you are thinking from the history as well as from the examination findings. So gradually you come to this thing instead of last analyzing it. Yes, they like it and they'll give extra marks. Yes. Thank you. Proceed, sir.
So, thank you, sir. So being a first session, I will take a little time for my word of thanks. First of all, I thank my president, Dr. Redhi Shantakumar, madam, for starting this type of session. Madam was very keen to start a PG academic session for IAP Thrissur, and she was very particular in starting such a session in our early periods of lockdown period itself, but somehow it is not materialized. And in our last TB, we have decided to start our academics program, and we are lucky to have our National Vice President Anandagasavan sir in our team, and Anandagasavan sir readily invited Srinivasan sir, and this program took off in a grand way. Thank you, Anandagasavan sir, for making this program a grand success and making this program happen. And and I also thank all the office bearers of IAP Thrissur, Mukesh sir, and also the IAP president, Dr. Narayanan sir, and also all the HODs of Thrissur, like Purushothaman sir, Vinod Jacobs, Zirian sir, and Ramraj sir, and also the Varma sir for joining us and supporting in this endeavor. And also personally thank Dr. Shalu for presenting this case and taking this challenge in a very sporty way. And thank you, Dr. Shalu, for presenting this case. And I also thank all the postgraduates who have joined us today. And also your participation is very vital for the continuation of the program. And I sincerely request honest feedback about this program, how to improve and how to, what you actually need from us like that.
About the teacher of teachers feedback. Okay. She has done a good job. I'm sure definitely they'll give a good feedback. But whether you invited the proper person or not, they have to give this thing, yes.
Yeah, we had around 99 people, 100 people are there. Yeah. Very good attendance also.
Yeah, very good.
Yes, also, we have many practicing pediatricians also joined us today. That's very
in spite of match. Yeah, success.
To have a relearning and back to school experience. I thanks once again so from the bottom of my heart to Srinivasan sir for this excellent session. Thank you all, and thank you all of you for joining us today. And hope we have another academic session tomorrow at 8 p.m. on tuberculosis, latent tuberculosis. That is very
Whenever you
important.
are racing, kindly send me this thing link so that I can also join and learn.
Okay.
Okay.
Actually, we are planning twice weekly academic regular.
I am attending Karnataka. They are inviting. So you don't mind, I can just be one of the person listening and learning. Thank you so much.
So thank you all of you, and good night from us.
Thank you, Dr. Ananta Keshavan and Madam, and all of you. So it's very nice. And thank you, Shalu, for a wonderful presentation.
Thank you, sir.
All the best. And all the best for all the other postgraduates you answered also. Thank you so much.
Okay.
Thank you.
Thank you, Shalu also. Thank you.
Thank you, sir. Thank you so much.
Good night.
Okay. Good night. Thank you, Dr. T. Thank you so much. So, Rati, please tell one word. So, did I do justice? Okay. Thanksgiving. Thank you. Shall we leave?
We can leave.
Yeah,
Thank you.
thank you.
Thank you very much.
Thank you.